Hello, viewers. This is Dr. Hassan once again live with you. This live is brought to you by Attract Media Services and Rainbow Children Hospital, Bangalore. Rainbow Hospital is one of the largest tertiary pediatric healthcare organization in India. And this week, our specialty is pediatric ENT issues. ENT means ear, nose, and throat issues. And this evening, we have Dr. Leena Balachandar with us. How are you, doctor?
I'm doing good, Dr. Hassan. How are you?
I'm fine. Thanks for joining the live.
Thank you. It's my pleasure.
Dear, dear viewers, let me give a brief about Dr. Leena. She is an experienced ENT surgeon, and she's experienced in otolaryngology and head neck surgeries. She's skilled in performing the procedures and surgeries such as adenotonsillectomy, ventilation, tube insertion, and microlaryngeal surgeries, snoring and sleep apnea procedures, and functional endoscopic sinus surgeries, endoscopic and microscopic air surgeries, and middle ear reconstructions. She is specially interested in pediatric airway procedures and phonosurgeries. She is research oriented and she has published two papers in international journals in otolaryngology. So, viewers, we are going to start our discussions now. If anyone have any questions, you can write to us directly to the comment box. So, doctor, before going to the main discussion, I'd love to know the COVID situation of your city right now.
COVID situation as in any other place of India. In Bangalore also the numbers are rising. And hopefully we would manage it within a period. I mean, we would contain it within a period of short span, same months. That is the hope all over the world and the same here. But as of now, the numbers are rising, and fortunately, we have adequate number of staffs, healthcare workers, and beds and hospitals to manage it. And most importantly, children are taking it much better, and there
Mm-hmm.
are not many complications or certain any unfortunate even in children. That is good news actually. So as
Yeah.
of now, yes, we have COVID situation and it's rising. So we'll manage it. We'll see.
That's great. So you have started to receive the international patients. You have already started to receive the patients internationally in this COVID situation.
Not exactly. So there are international patients who are staying in India for quite long time because they have certain chronic issues and
Mm.
they have to undergo like long-term treatment. So we are seeing those kinds of patients. So
Mhm.
I mean, I cannot say for other departments and other specialities. And for as of me, I have not received international
Okay,
patients like after this pandemic started.
because the flights are closed mostly,
Exactly,
and the
exactly.
visa is not been permitted. Okay then.
Hmm.
So today our topics is the noisy breathing and snoring in children, right?
Yeah.
So let's get into the main discussion. Why noisy breathing occurs?
So noisy breathing is like any physiological phenomenon. Noisy breathing occurs due to any partial obstruction in the airway, the airflow in the airway. So it starts anywhere from nose until the lungs, where the air column is there. So to put it in simple terms, it's like flute. So when the air column passes through flute, and you just obstruct in particular position, it creates particular note. So the same concept, air flows from your nose to lungs, and when it's blocked in certain positions, there is noisy breathing. So we will see it in detail, like which part is blocked and what kind of noise it occurs and what it is called as and all those things. Probably we can go with the flow of discussion. Yeah.
Okay. So you were about to tell something about the ENT. Actually, you are a pediatric ENT specialist, right? So what is the difference
Correct,
between the
correct.
the elderly ENT specialist and the pediatric ENT specialist?
Okay, so the basic difference is children are not exactly a replica of young adults. We don't see children as young adults. So there are certain issues in children which are exclusive to children, to certain age group. There are certain issues in which are exclusive to newborn babies. So a pediatric ENT specialist is trained in that particular aspect, that dealing in that a particular illness or consequences, whatever it is. So the pediatric ENT specialist is trained to handle certain diseases in this particular age group. So in ENT, there is a broad terminology, there is a broad category. So
Okay,
we are trying to handle this one.
that's great. So is noisy breathing common in children? Is it very common?
Yes, it is very common. common. So anyone can have a transient noisy breathing. So you and me, if we have a common cold or flu, when our nose is blocked and stuffy, we will have noisy breathing. We will have snoring, maybe to a certain extent. So noisy breathing is common. Each and every child may have noisy breathing when they are having a episode of cold or allergy or flu, seasonal flu, something like that. So there are certain conditions in children where the noisy breathing may not be transient, it could be continuous. So we are focusing on those particular conditions where the children will be having noisy breathing throughout a month or for a longer duration. So we have to
Hmm.
focus on that particular condition.
Okay. Actually, the noise differs according to the level of obstruction.
Correct. Yeah, it differs according to the level of obstruction. As I gave the example of flute when we started this conversation. So when the obstruction occurs at one particular level, it creates one particular kind of noise. So when you have a stuffy nose, you could feel that you may have certain noisy breathing, and people can just ask whether you have a stuffy nose or not. I mean, no one will know the technicality of it, but they will ask whether you have a stuffy nose or not. So if we have a obstruction in throat, yes, that produces
Mhm.
certain kind of noise. It is called a stutter, or sometimes it could be snoring also. If we have a block in the voice box level, just above or below the voice box, it is called a stridor. That will be a high pitched noise. So the according to the level of obstruction, starting from nose until the lungs,
Mhm.
the pattern of noisy breathing varies.
Okay. Now come to the point of the snoring. The
Okay.
children may have snoring, right? Is it normal?
Yeah, children may have snoring, especially infants and toddlers. They will have snoring. Most of the times, they will have snoring. They will have open mouth breathing and all those things. Just because the anatomy itself, there'll be a little bit of fat, more fat in the base of tongue, and there'll be the anatomy of neck itself. They may have snoring to a certain extent, and it could be aggravated by when the child is having a runny nose or nose block due to any other condition. So children will have little bit of snoring, transient snoring, but it is considered abnormal when they snore throughout the night, or when the snoring is continuous, like for days or months or years together, and
Okay.
if it disturbs the sleep.
Mm-hmm. Okay. What to do if a child snoring is a continuous process? If you regularly do the snoring and all, what to do then?
So if the child snores continuously, for example, we can take a 2 or 3 years old child, or even an older child also. If the child snores continuously, obviously you will be meeting the parent will be meeting a pediatrician, like for anything like vaccination, or the child may have certain issues. They'll be obviously meeting the pediatrician. So the first alarm comes usually for us, for ENT specialists. The first alarm comes from the pediatrician. So the pediatrician will say that the child is snoring, but I don't think the snoring is normal to a certain extent. It's better to meet a ENT consultant. So that is how a child lands up in my OPD most of the times.
Mm-hmm.
So when someone comes with snoring, usually the I'll ask like how long it is there, and what is the pattern of snoring, what is the position of the child when the child is sleeping, when the child is hyperextending neck like this, or the child is struggling to take breath. This kind of history taking will be there. And according to that, of course, examination. With clinical examination, we will figure out like why the snoring is happening and what could be the reason behind it and how to handle it.
Okay. So what are the treatment options for snoring?
So again, snoring depends. Happens due to multiple reasons. In a child, the most common reason is adenoid and tonsil enlargement. So adenoid and tonsil are the normal structures you know, which when enlarged to certain proportion, it can
Mhm.
cause the block pain and it causes snoring. So in a child, whatever be the age group, starting from 1.5 to 2 years, or like 12, 13 years, adenoid and tonsil enlargement is the most common reason for snoring. So we will be
Okay.
seeing whether it could be manageable with medications. There will be
Mhm.
a trial of medications, of course, to start with. And if the child responds to medicines, yes, that will be the management. If the child is having frequent episodes of symptoms which needs frequent medications, or if the child is not responding to medications, then comes the surgical management. So there
Okay.
are other reasons for snoring as well, apart from the most common adenoid and tonsil enlargement. Sometimes there is something called lingual tonsil or lingual thyroid, which blocks the backside of the tongue and blocks the airway. Sometimes there are other issues. Sometimes there could be anatomical, craniofacial malformation. Like the
Mhm.
child will be having like the jaw will go backwards or the neck will be short. Those kind of anatomical malformations also. And
Okay.
these child also will be snorers. So there will be like surgical management and management through positive pressure ventilation. Surgical management, whatever be the structure which is blocking the airway, as to put it in simpler words, I'll be removing the structure. And the positive pressure management is if the child is not ideal candidate for surgery, if it's due to some other reason, if the surgery is contraindicated, or if there is multiple anomalies which can block the airway, we advise positive pressure ventilation, where the child will be sleeping with a mask over the nose and mouth, and air will be like pushed inside the child's nose, so that it, due to the positive pressure, that it opens up the airway and the child sleeps comfortably. So these
Okay.
are the treatment options available.
Oh, so firstly, we have to try for the conservative treatment. After that, if surgery
Exactly.
needed, you have to go to the surgeries. Okay, then,
Exactly.
what is the obstructive sleep apnea?
So apnea is something where the person stops breathing, cessation of breathing for a short term. Like, I mean, it's understandable. It is for short term. So when a person is snoring, when the child is snoring continuously, the airway collapses gradually, slower and slower. At some point of time, the airway collapses too much, and the child or person cannot breathe normally. So what happens at that time? Your brain wakes up your body. So the body wakes up and your brain gives a signal for you to breathe. So this is the pattern of obstructive sleep apnea. So so this is the pattern of obstructive sleep apnea where the oxygen saturation will be falling, and at some point of time, at a critical point of time, the person wakes up and then the oxygen saturation goes back. So if this cycle continues throughout the night, the child or a person will have very very poor quality of sleep, and there will be daytime restlessness, daytime irritability. And I have seen many children who has been branded as hyperactive kids. When we probe the history, I'll come to know that the child is suffering from obstructive sleep apnea. So just because the child is not sleeping properly in night, the child is irritable and branded as hyperactive in daytime. So in short, this is obstructive sleep apnea. Body receives less oxygen, lesser and lesser, breathing stops, and then comes back to the level one or stage one.
Okay, so what can be the treatment options for it?
So the treatment options is again positive pressure ventilation or surgical management. First, obviously, we have to find out what is the reason for obstructive sleep apnea. So the causes which I have mentioned, few minutes back. So according to the reason, the treatment option varies, but broadly to categorize, it is either conservative management with CPAP and or BiPAP, which is positive pressure ventilation, or if the child needs surgery, then will be the surgical management.
Okay. Can the noisy breathing may happen in a very much newborn baby?
Yeah, definitely. So newborn babies have certain things which are exclusive to them. To start with, the newborn baby can breathe and drink at the same time, which we cannot do obviously.
Hmm.
So the larynx, the voice box, and the entire structure is designed for them accordingly, so that they can breathe and sleep. Drink at the same time, so that doesn't affect the feeding cycle of newborn. So, due to the exclusive anatomy of the newborn babies, sometimes they may have this kind of noisy breathing. So, noisy breathing in a newborn is more common than we think. The baby will have noisy breathing. The baby may have a little bit of retractions, like about just above below the in the root of neck and the chest region and all those things. Yeah. So, to put it in short, yes, newborn babies can have noisy breathing.
Okay. What is stridor?
Okay. Stridor is the terminology which is given for noisy breathing when the obstruction happens at the level of voice box, just above it or below it. So when the, I mean, as I previously mentioned, when the obstruction happens at multiple levels, the quality of sound differs, and we call it with different terminology. So the term stridor is given to the to the quality of noise, which will be usually high pitched, which happens when the obstruction is at above or below the area of voice box. It can happen during inspiration, or it can happen during expiration also.
Okay. Okay. So, what are the reasons of it?
So there could functional obstruction to start with. As I said, in newborn babies, the anatomy of larynx is a little bit different from I mean, a toddler or
Larynx.
a older children. Larynx
Larynx.
is the
Larynx.
like
Okay.
voice box. Yeah, voice box.
Yes.
So, due to the anatomy itself, the stridor happens. That will be functional. So, what happens in newborn babies or very young babies? The larynx, the and the
Squeezing.
structures just above that, it can collapse a little bit whenever the baby is breathing, and that can cause stridor, which is called as laryngomalacia, and that is the most common cause of stridor in a newborn baby. So apart from that, there are multiple other reasons also. There are certain conditions which are exclusive to newborns. There is something called cyst in the valvular region between the tongue and the voice box. Or just below the voice box, there could be cyst. Cyst is nothing but fluid fill accumulation. You will be, obviously, you'll be knowing that.
Okay.
Or the airway itself could be constricted, which could be congenital problem. So there are multiple issues which can cause stridor, especially in a
Okay.
newborn babies or a young child.
Okay. Is there a test available to know why noisy breathing happens exactly?
Yes. So by clinical examination, all we can say is like, yes, the child is having noisy breathing. We can grade
Mm-hmm.
how severe it is. But to see, I mean, to say why it is happening, we have to do an endoscopy always. I mean, endoscopy is like we'll be putting a small camera kind of thing inside the nose, visualizing the nose, throat, and the airway, the windpipe, trachea area, and all those things. So that is a test. Unless we visually make see the region where the problem is, we cannot say, well, like, why the noisy breathing happening. That is one gold standard test to detect why it is happening. So there are two types. One is flexible, where we can see the nose and throat in the OPD itself. It is basically an office-based procedure. So we will be putting a flexible endoscopy, which through the nose and visualizing nose, throat, and until the voice box. So in
Okay.
babies, it is usually safer to do this flexible endoscopy until the voice box, not below that. So, if we have any doubts in that, or if we think that the baby needs even better examination, we go for something called microlaryngobronchoscopy, which will be usually done under general anesthesia in the operative theatre. So, these are the tests, these are the gold standard tests. Apart
So,
from that, for certain conditions, sorry, yeah. Apart
yes.
from that, for certain conditions, we advocate doing a CT scan or swallowing assessment. So, those are ancillary tests.
Okay. Is endoscopy safer for a newborn?
Definitely, it is safer. So, as I said previously, it is a flexible scopy which is not going to harm, which is not going to cause any pain to the newborn. Of course, it is
Okay.
going to be uncomfortable, and it is completely safer to do it in the OPD as an office-based procedure. But we will take a call. Like, if we think this child newborn has certain other issues where it is not safer, we will go ahead and do it only. But normally, for a normal baby, or even with a baby with stridor, it is safer to do it in OPD, no problem.
Okay. Now we are coming back to stridor once again. What are the treatment options available for it?
The treatment options differs according. I mean, again, it differs according to the reason why the stridor is happening, where the
Mm-hmm.
block is, what is the pathology, main pathology, and all those things.
Mm-hmm.
So usually the treatment option will be conservative, which is wait and watch. We're not going to do anything. There is no specific medications for it. There are no medicines to if the child is having stridor chronically for a longer time, there is no specific medicine for it for to cure it. So the treatment option is either to wait and watch, or to do a surgical procedure depending on the cause exactly. So during this wait and watch period, we may give certain medicines like anti-reflux medication to reduce vomiting, because like if the child is vomiting continuously, that is going to irritate the throat part and it may increase the damage to the tissue. So these are the, in broad, these are the treatment options available. Either conservative management, just wait and observe to see if the stridor goes down on its own, or if there is certain condition which needs surgical management, yes, go ahead and do the surgical management.
Okay. So usually doctors say that noisy breathing in the newborn will be settled down after 6 months. Is that so?
Yeah. So when we see a newborn baby, like within 1 or 2 days with noisy breathing, which doesn't appears to be severe, there are certain other criteria to say if the noisy breathing is severe or not. If the newborn baby doesn't have severe noisy breathing, mild, which doesn't affect their feeding habits, then we
Mhm.
usually prefer to wait and see if the noisy breathing settles down. But there is no hard and fast rule like 6 months. It could be like 1 or 2 months here and there. So, as I told previously, due to the exclusive anatomy of the newborn larynx, there could be noisy breathing. We just wait to see if it settles down on its own. If the child is having mild noisy breathing, mild stridor.
So if it's not settled down within 6 months, so what to do? What if?
So yeah, so I specifically told if it is mild, we will wait and watch. If the stridor is severe, there are two conditions. If the even if the newborn, if, 1 or 2 days baby, or even like 1 week or 2 weeks old babies, if the noisy breathing is severe, when the child cannot able to take feeds properly, there are so much of retractions, or the child has to be on any respiratory support to breathe itself, then we will go ahead and do this endoscopy to assess what is the problem exactly. Or as you asked, if the noisy breathing doesn't settle down even after 6 months of age, associated with poor weight gain. So again, we'll move ahead to do this endoscopy to know the diagnosis exactly. So the main reason for advising endoscopy is like I have to know what I am dealing with. So I have to know whether this particular condition we can afford to wait, or there are certain other conditions where we cannot afford to wait. We have to go ahead and do some sort of intervention as early as possible.
Okay.
So yeah, in severe, that is the next step.
Okay. So when a parent should be concerned about the newborn's noisy breathing? When a parent should concern?
Yeah. So in a newborn, if the newborn cannot breathe on its own, like if the newborn baby needs some sort of respiratory support for breathing, yes, that is the
Hmm.
first main thing to be concerned.
Hmm.
Or if over a period of time, like for when the parent is observing the baby for a few days and they are noticing that the baby cannot breathe and drink together, like if the baby has to stop feeding to catch a breath, that is
Okay.
another reason where they have to just think about it, some sort of issue in the back of mind. Or over a period of months, weeks or months, if the newborn's weight gain is not appropriate, if the weight gain is not happening adequately, then yes, they have to be concerned. Or along with noisy breathing, there is retractions. The neck part goes inside, or the chest part goes inside whenever the child is breathing. Yes, that again is something which the parents has to. I mean, they it's better to get medical opinion at that time also.
Okay. What are the surgical types of surgical options available?
Okay, the surgical options completely depends upon the diagnosis, like what is the
Mm-hmm.
problem which is causing this noisy
Mm-hmm.
breathing. So I was
Mm-hmm.
telling that laryngomalacia, the anatomical issues in the newborn can cause this kind of noisy breathing. And I was telling that wait and watch or surgical management and all those things. So in those kind of severe laryngomalacia where the baby
Mm-hmm.
cannot able to breathe normally, or there are certain other issues, in laryngomalacia also we advise some sort of surgical management. And again, if there is cyst, the water filled pouch in the tongue base or anywhere in the throat, or if there is
Mm-hmm.
narrowing of the airway, there are multiple surgical options available depending upon the diagnosis. Most of the times, the surgical options will be endoscopy. Say, for example, when laryngomalacia, I'm talking about laryngomalacia, the surgery will be done endoscopically, just through the oral cavity itself. There will not be any external cuts or anything. There are certain other conditions which needs open surgical approach. When
Mm-hmm.
the airway is too much narrow, when it is like the segment is completely narrowed, yes, that needs an open approach. Or if there is any other associated abnormality, that needs an open approach. So most of the times the surgical management will be endoscopic approach.
Okay. Can you tell us a few lines about cochlear and Baha implantation?
Okay, so it's a completely different topic.
Yes.
Cochlear implant. So cochlear implant. Just a few words before that, the how ear functions and all those things. So what I say usually is ear functions as a landline telephone, where the sound energy is converted into electrical impulses, and the electrical impulses are transmitted to brain, where the brain perceives and identifies those electrical impulses. So when the sound transmission is obstructed, that is called as conductive hearing loss. When
Exactly.
the mechanical to electrical impulse transmission, that kind of conversion is affected, or when the electrical impulse transmission is affected, that is called a sensory neural hearing loss. So ear is divided into multiple segments. This kind of conversion happens in inner ear, which is called as cochlea. And if there is any abnormality in cochlea which hinders with this kind of sound transmission or sound conversion, then there comes the role of cochlear implant. So where we insert a electrode in the cochlea, and the electrode will take over the function of cochlea, and it will the child or adult will have normal hearing.
Hmm.
So mostly it is done in children who have congenital hearing loss, that is sensory neural hearing loss. So again, cochlear implant is a surgical procedure where the implant will be introduced into the innermost part of ear. The electrode will be introduced into the innermost part of the ear, so which will do the sound conversion mechanism. And Baha is again that is an implant when the conductive component is hindered. So when the mechanical sound, the sound impulse cannot pass to the innermost part of the ear. Say the child doesn't have a ear at all, the external part of the ear at all, but the inner ear is completely normal. There comes the role of Baha, where we attach the receiver here so that it receives the sound impulse, and if it directly projects it to the innermost part of the ear, and the function happens on its own. So in short, these are, yeah.
So, what is the success rate actually, the cochlear implantation surgeries and all?
Okay, so cochlear implant is that is a electrical device. So the success of that electrical device is going to be 100%. The device is going to do that device's function 100%, unless it has some battery issue, something like that. So what are the challenges? It normally for a child it takes like 1 to 1.5 years to develop some sort of language, to the child to start say up and all those things. Why that 1 to 1.5 years gap? Because during that time the child has to receive multiple sounds, understand multiple sounds, and then try to reciprocate it. So that is why the gap of 1 to 1.5 years in any normal child. So what happens in after cochlear implant? The child who has not received any sound impulse at all. See, if we are, for example, if you are doing a cochlear implant for a baby at the age of 10 months or 12 months, until that time the baby has not received any impulse at all, or some little bit of sound impulse, which the baby may not be aware of. So suddenly, after a period of 8 months, the baby is receiving some sort of impulse. So it takes certain time for the baby to understand what is the impulse, what sort of sound it is, and it takes even more time to understand language. So I am speaking now continuously. For a child to understand that language, even at the age of like 1.5 years or 2 years, when the child is implanted at the age of 2 years, the child is not going to understand what I am speaking.
Mm-hmm.
All the child is going to hear is some sort of noise. For that, for us to make the child understand what the sound is, what language is, and how the child has to reciprocate, it needs minimum 1 year. So after the cochlear implant, we will be advising therapy, audio visual therapy, and the child has to undergo that. Then the child will start to speak normally, and that is a normal, usual process.
Okay, what is phonosurgery?
Okay, phonosurgery is something where we to enable our voice. I mean, if say if I have hoarseness in voice, so phonosurgery is something where the surgery is done in the voice box to correct the voice. So if I have hoarseness, like what could be the reason for hoarseness? There could be such certain things called vocal nodules, or um, the vocal cords, the voice box, the vocal cords in the voice box, it has to approximate when we are speaking, and it has to vibrate when the air column comes out. That is the basic
Exactly.
mechanism.
Exactly.
So phonosurgery is something which is done in on the vocal cord or just above or below that to enhance the quality of voice or to correct the quality of voice. There could be certain reasons why the quality of voice is not proper. If the vocal cord doesn't approximates, then the voice quality will be hoarse, breathy. If there is some cyst or some nodule or some polyp, some growth in the vocal cord, which is going to affect the approximation, yes, that is going to cause problem. And doing surgery in that particular part of voice box to enhance the sound quality, to make it normal, that is called as phonosurgery.
That's great. So you have expertise on adenotonsillectomy. Can you tell us a few words about that?
Yeah, so adenotonsillectomy is the procedure where I told like removal of adenoid and tonsil. Adenoid and tonsil is they are not abnormal tissues; they are normal tissues which has grown, due to which it creates some trouble. So most of the times it will be frequent episodes of infection, upper respiratory tract infection, or it
Hmm.
obstructs the airflow and it causes like certain troubles like snoring and mouth breathing and
Hmm.
all those things.
Hmm.
So what happens when the child breathes through mouth constantly? When the child breathes through mouth for years together, that alters the facial feature. Like as humans, we are not designed to be a mouth breather. We are designed to be a nasal breather. So
Hmm.
when the child breathes through mouth continuously, it alters the facial features. So
Hmm.
the upper row of teeth comes in front and the cheekbones get backwards. There is something typically called as adenoid facies. So these are the
Hmm.
things which can happen when the child is having adenoid and tonsil enlargement for a longer time. So that is why we advocated to get it removed if it creates this kind of issues. So normally I do it here by a method called coagulation, where the physics of coagulation is like it creates a field of saline and it vaporizes the tissue, to put it in simpler words. So the advantages, the hospital stay is lesser, the bleeding is lesser, which is a very big advantage for a surgeon, and the post-operative pain for child will be lesser compared to the normal technique where we remove it by scissors and all those things. So usually we'll admit the child on the day of surgery and we'll discharge on the same day or the very next day. So
Okay.
these are certain things about adenotonsillectomy.
Okay. Thank you, doctor. Thank you for a valuable
Yeah.
time. Thanks for
Thank you
joining
so
the
much.
Thanks for
Yeah.
joining the live. Your discussion was so informative, and hopefully it will be so helpful for our viewers too.
Yeah. Thank you,
So
Dr.
thank you,
Hassan.
doctor. Thanks for
Yeah.
joining.
Bye.
Thanks for joining the live.
Thank you.
Bye. Thank you, doctor. So viewers, thank you. Thanks for joining the live. Thank you so much.